Hello, everyone. Welcome back. So today we're going to be discussing chronic fatigue syndrome, which is something that I have a lot of experience with because I've been researching it for 2 years. So I'm really excited to talk about this. So chronic fatigue syndrome gets much less attention than fibromyalgia. And we discussed fibromyalgia in the previous video. So if you haven't watched that one yet, please check that one out. And I actually talked a little bit about chronic fatigue syndrome because a lot of the symptoms are very similar. So, why is it not as famous as fibromyalgia? Because it still impacts millions of people around the world. So it's not that it's rare, it's just the conditions are so similar that a lot of doctors and a lot of people and a lot of pop culture, um, influencer people on TikTok, for instance, who are talking about this, they usually just push it under fibromyalgia or they don't really discuss it, but they are actually two technically distinct conditions. So, again, let's go over the symptoms a little bit. So, the symptoms are pain in joints, fatigue, inability to concentrate, sleep problems, and there's of course other possible psychological problems such as depression and anxiety. And there's also post-exertional malaise, which is where if you do an activity and then you feel exceptionally tired. And these fall under what is known as the Fukuda criteria. Now, this was published in 1994, but it's basically one of the golden standard of diagnosing chronic fatigue syndrome. And this fatigue is what defines the condition. It's not the pain, it is the fatigue. So, as we discussed in the last video, while fibromyalgia and chronic fatigue syndrome both have pain and fatigue, fibromyalgia's primary symptom is pain, while chronic fatigue syndrome's primary symptom is fatigue. So, it is still very hard to distinguish them, especially in a clinical setting, because they can present very similarly, and actually, a lot of people end up getting diagnosed with both. So again, there's a lot of overlap. However, one thing that is important to mention is the ratios for the sex of the patient is very different. So there are some studies, I should clarify, in fibromyalgia that do say that it's much more predominantly in women, but that's because women can tend to get diagnosed more with fibromyalgia. The more realistic estimates are somewhere close to a 60-40 distribution, where 60% are women and 40% are men. In chronic fatigue syndrome, on the other hand, it is overwhelmingly women. Nearly 80% of the cases are women. So in this case, and again, when we in the lab, when we ran the research study, we only included women participants because most people who have this condition are women. So we wanted to focus on the genetic biomarkers in women specifically. And the gender disparity in this case is very important to understand because, again, the gender disparity in the conditions mean that the people who suffer from the condition are also more likely to be marginalized in society. And so we need to discuss the inherent sexism that is found in the medical field. And while we have made great progress in this area, it is not really possible to take out the history of sexism that is found in medicine. And of course, in the previous video, we talked about J. Marion Sims, for example, the founder of the field of gynecology, and how he treated African-American enslaved women. And so, again, these are not exclusive to just fibromyalgia or to chronic fatigue syndrome. They, of course, interplay, but I want to highlight different topics in each video so that you guys have a more broad exposure to different systemic inequities. So, let's go over the history of medical sexism just very briefly. So, again, the 1900s, the early 1900s, is the first time that medicine is becoming institutionalized. There's a system of medical schools that start to operate. There is a board of physicians that start to come together. And yet, despite this growing movement towards institutionalism and scientific method, the pain women women experience is quickly dismissed by doctors. So a lot of women who experienced menopause were labeled as hysterics, and the doctors didn't really offer any emotional support. The pain was dismissed as mere emotions, and this is kind of the area of medicine known as the paternalistic model. We are trying to move away from that. It's a more patient-centered model now, but then again, there is still that um, I influence felt. And thanks to the feminist movement of the 60s and the 70s, medicine has started to change. More women have become doctors. Nowadays, 50% of women in medical school are 50% of the students in medical school are women, for instance. And there is also greater empowerment due to increased use and legalization of contraceptives and abortion, so women could have more control over their body. And yet, despite these advances, disparities in medicine never truly went away. They're obviously not as pervasive and as powerful as before, but they still very much impact healthcare. And this is not just a U.S. problem. In fact, U.S. is doing comparatively better than a lot of other countries. An example that I learned about when I traveled abroad to Nepal was in rural villages. This is not obviously everywhere in the country, but in rural villages where there's not a lot of information about healthcare, women who are experiencing their period are considered dirty, especially spiritually, and so they're not allowed to touch anything, they're not allowed to be in the house, and there's a separate cabin on the side of the mountain where they have to live until their period is over. And so this cleansing process is actually very deadly because, again, this little hut is not really well supplied, it's very cold in the mountains, and so there's a lot of cases where women just have died because they're rejected from their households. But what does this disparity really look like in our society? I know it's very hard for us to relate to the problems in Nepal, but again, there is still sexism in America. So let's talk about that a little bit. Well, a prime example is actually one that's very common is the process of inserting an IUD. So IUD is a birth control measure that is very effective, and sometimes it is also inserted into a woman because it is helpful in reducing extremely painful periods. And it is very effective, it's also very safe, but the process of inserting the IUD can be very painful. And the pain medication could be offered. It wouldn't compromise the procedure. And there are several cases, especially highlighted on social media, where pain medication is not really offered to women who are undergoing this procedure. So it's a very traumatic and painful procedure. And there is even a highlighted case of a woman who was in this operation, and her boyfriend was the one that medical professionals gave more attention to because they thought that he was feeling uncomfortable. Now, another even more painful and more serious condition is endometriosis. This is something that I have experience with. I have worked to create awareness about endometriosis when I was in high school, and I shadowed a doctor who was working with endometriosis patients. So I have firsthand exposure to these patients, and I know how debilitating this disease can be. It's where this endometrial lining inside the uterus grows in areas where it shouldn't, so maybe it can grow in the outside of ovaries. That's a common place for them to grow, and it's a very sticky substance, so it causes the ovaries to stick, and as a result, it's very painful. Every time you walk, every time you engage in sexual activity, for instance, it is a ripping of the tissue, and so it's very debilitating. And yet, despite a growing amount of research and experience and training, it's still very difficult for women to get a diagnosis for this condition because doctors frequently dismiss them. Because doctors say that, oh, you're just experiencing periods, you're just exaggerating your pain, you're just having regular period cramps, and so they have to go to many doctors and wait for years before they can get a diagnosis. And this wait not only increases their pain, but also increases their chance of losing their fertility and other medical complications, and also makes the surgery more complicated. So again, there is this mindset among some medical professionals where they don't really trust um, women. They think that women are exaggerating their pain, and this really destroys the bond between a patient and their doctor, because women feel like they're not being heard, and doctors think that they're just lying. So both sides are not really participating in a beneficial patient-doctor relationship. And this culture impacts chronic fatigue syndrome as well. Considering that most patients are women, the condition is labeled more often as an emotional problem that reflects the personality of the people rather than a legitimate medical condition. And when women display depression or anxiety due to the condition, they're labeled as overly emotional. And when they become withdrawn from social activities or from chores, they're labeled as lazy. So there's not really any winning for the patients. And they even have trouble discussing their pain and fatigue. Because they're quickly dismissed as being hysterical, and this dismissal is a part of the vicious cycle of emotional isolation. And this actually plays into one of the most commonly highlighted problems with gender equality in our country, which is that of pay equity. Of course, there's many reasons, such as the fact that women tend to work fewer hours than men, and that women are more involved in family rearing and household chores. But a contributing factor is also the fact that women, since there's millions of women in the U.S. who experience chronic fatigue syndrome, since they experience chronic fatigue syndrome, cannot even bear to complete simple chores or go to work. They have to quit their jobs or lessen their working hours. So they're more likely to be not just socially isolated, but also economically dependent and not able to support themselves because of their condition. So what can be done? Of course, there is still hope. First, women's advocacy groups need to embrace chronic fatigue syndrome as a women's rights issue. CFS does not really get any attention from the media, does not really get any attention from the broader public, even though there's millions of women impacted. And it affects some of the causes, like the wage gap that these women's advocacy groups frequently advocate against. And yet, because CFS is not really mentioned by these groups, an effective solution is not always brought forward. And again, just like with fibromyalgia, there's also a need for community support groups so that people who have chronic fatigue syndrome are not feeling isolated. And third, we must introduce women's health to school curriculums from an early age. Again, this doesn't necessarily have to be sex ed, but we need to be talking about men's and women's health from an early age. So because a lot of these conditions first start in teenage years. So teenagers can be on the lookout for some of these symptoms, and so they can work to get a diagnosis and treatment earlier on so that their condition doesn't debilitate them in college or in their working life. And this doesn't necessarily have to be through a school, but it can also be done through a public health program like a community health center to raise awareness about amongst young girls. And it becomes clear overall that CFS is intricately tied with social inequities, and it reinforces stereotypes about women and also hinders them from participating in the workforce, thereby improving their socioeconomic position. So next video is going to be about the Gulf War illness. So I'll be discussing the history of the Gulf War, and I'll be discussing the condition and how it impacts veterans' health. Again, thank you so much for watching, and I'm really excited to publish today's video. So once again, thank you very much.